Okay, another quick switch. We were having a couple technical difficulties, but I think we're all set now. And we have Carolyn Levita, who's the director of our respiratory care services here at MGH, who's going to give us two back-to-back talks, and her first one will be non-invasive respiratory support. Thank you so much for being here with us.
Thanks, Catherine, and good morning, everyone. As Catherine mentioned, we'll talk about non-invasive respiratory support for acute respiratory failure to determine if less may be best or not. I do have some disclosures to let you know about. I don't think any of them are relevant to this discussion today. In terms of non-invasive respiratory failure, the three main therapies are really heated high flow nasal cannula, continuous positive airway pressure, and non-invasive positive pressure ventilation. I'll briefly describe some of those to understand and really level set to make sure that we really understand what the therapies do and what their intentions are. We'll talk about if they're equivalent, when one can be replaced perhaps with another. We'll talk about the different select patient populations that may benefit from each and if there's any crossover. And then I'll talk a little bit about some technical considerations. As a non-invasive therapy, the technical considerations can really either aid in the success or contribute to the failure. So working on those and understanding those is very, very important. We'll start off with heated high flow oxygen, which has really come into popularity, increasingly so over the last decade. The physiologic effects of heated high flow oxygen are actually a few, really. There's precise and accurate delivery of the FiO2 that you desire. There can be some establishment of PEEP with an increase in FRC. This improved PEEP can really help let me rephrase, it may help with the gas exchange as well as the work of breathing of the patient. We will talk about the limitations of PEEP with heated high flow oxygen therapy. There's also washout of the anatomic dead space, and I'll go through each one of these in a little bit more detail. With a standard oxygen nasal cannula, a patient whose normal quiet breathing has an inspiratory flow rate of around 30 liters per minute. If you were to add a nasal cannula at 1 liter per minute, you're getting 1 liter per minute of an FiO2 of 1.0. That means that the patient has to entrain room air, 29 liters of room air at an FiO2 of 0.21. By doing some proportions and math, you get a net FiO2 on a 1 liter per minute nasal cannula of about 0.24. And again, this is normal quiet breathing at a standard oxygen nasal cannula. The intention of high flow is that when we add high flow, we're either meeting or exceeding the patient's inspiratory demand. So if the high flow nasal cannula is set at a flow rate of 50 liters per minute with an FiO2 of 1, and the patient's inspiratory flow rate is 30 liters per minute, then their net FiO2 is still 1, right? They're not entraining any room air to, if you will, dilute the FiO2 that they're inspiring. This will also hold true if the patient gets into maybe some respiratory distress intermittently where their flow rate increases. Even if it goes to 40 or 45 liters per minute, we're still exceeding that, so the FiO2 is guaranteed. You can imagine a patient who's in respiratory distress and perhaps has, some tachypnea, increased inspiratory flow demands. That can really be exacerbated if the net FiO2 is substantially decreasing. So if we're meeting or exceeding those flow rates, then the FiO2 will stay the same. The patient will not become hypoxic, and that will not contribute to their increased work of breathing. The washout effect from high flow nasal cannula is actually well described and very impactful. We see this a lot for patients who have perhaps borderline gas exchange, but an increased work of breathing. It's very, very dramatic in children with bronchiolitis. When you put on high flow, so let me just talk through the picture, sorry. On the figure A, when a patient typically exhales, their nasopharynx, oropharynx, hypopharynx is filled with carbon dioxide. That is the first column, partially filled. That is the first column of air that is then inspired on the subsequent inhalation. When you place high flow nasal cannula on a patient, because of the flow rate, it's incredibly difficult to expire against it. So often expiration occurs through the mouth. The nasopharynx is filled with oxygen, whatever FiO2 you have set. So then on the subsequent inhalation, you can imagine that the inspired FiO2 is higher and the inspired CO2 is lower. This in and of itself can really unload the work of breathing of these patients who have significantly higher work of breathing, but are actually maintaining their gas exchange. Again, we see this often in children with bronchiolitis, with RSV. We also can see it in some patients with COPD. High flow nasal cannula is typically thought of as a device for hypoxemic respiratory failure. For people who have, again, they can defend their CO2 and their acidosis, but have a higher work of breathing. The high flow nasal cannula can help that and can, offload some of that work of breathing. Often we're asked to put high flow nasal cannula on for the PEEP effect. And I will just caution you with this. There certainly is, because of the high flow within the system and because of the fitting of the prongs, they're a wider prong and they fit more snugly in the nair, pressure can develop. The question is that pressure actually transmitted in a meaningful way, in a therapeutic way? This study that was done 10 years or so ago now looked at pharyngeal pressure, which is probably the best that we can do. And at what flow rates develops which pressure. The general rule of thumb is for every 10 liters a minute of high flow nasal cannula flow that you have, you're probably generating about 1 centimeter of water of CPAP. Now that is under the most optimal conditions, which includes a very snug fit of the prongs within the nair. It also includes the patient's mouth to be closed. If the mouth is open, a lot of this pressure is leaked out, or it's not recognized because exhalation occurs through the mouth instead of through the nose, where the back pressure is developed from that high flow. So again, I think we need to take this with caution. There is some pressure that's developed, but I don't think if we're needing positive pressure, needing positive end expiratory pressure, that high flow is the most appropriate device to use. The other component of high flow oxygen therapy is the fact that it is heated and humidified. This really can aid in secretion clearance. It actually, having the two of them combined at these high flow rates aids in patient tolerance. Placing high flow oxygen on a patient that's not heated or humidified is actually incredibly uncomfortable, and patients will be intolerant of it very, very quickly, which can lead to failure of the therapy. The way that I like to think of high flow oxygen therapy is really to use it when your clinical picture is related to either diffusion or perfusion defects within the lung. It's really not meant to treat patients who have, atelectasis or, pulmonary edema, that sort of thing. It's really when there's diffusion defects or perfusion defects, like a large PE, that high flow oxygen therapy is most effective. As I mentioned, the positive pressure generated is really insignificant. It's not what you want for the patients, and I don't think that you'll often see rates of failure being very high when you're using it in replace of another device that can actually deliver CPAP or BiPAP. It's not quite ventilation, but there is an impact, as I mentioned, on the CO2 clearance for that upper airway washout and that reduction in anatomic dead space. Once again, this is definitely a review for all of you for non-invasive positive pressure. There are two different modalities, CPAP and bilevel. This picture, I think, depicts exactly what it can do and the difference between the two, where this normal quiet breathing is really set at a baseline pressure of 0. When you apply CPAP, you just elevate the normal breathing off of the baseline, right? So you're adding pressure on the expiratory side only, the expiratory phase only. Depending upon the device, it's either called CPAP or EPAP, which is expiratory positive airway pressure. There is no inspiratory pressure applied to every breath. So therefore, the muscles are not unloaded. There is no improvement in work of breathing if it's related to poor compliance. Bi-level non-invasive ventilation, BiPAP, they're all interchangeable, which can be incredibly confusing, but it elevates the breathing off baseline again because you are applying CPAP or EPAP. But in addition, it adds an inspiratory pressure or IPAP to really change the patient's CO2, to augment the tidal volume, and to offload some of the respiratory muscles that the patient may exhibit increased work of breathing. We'll talk about this a little bit later, but some of the technical considerations with this is you have to understand which device you're using. Some of the ICU ventilators, when you're setting BiPAP, you're actually setting the CPAP level or the EPAP level plus the driving pressure. Some of the home devices that are used, you're setting the EPAP or CPAP level, but in fact, you set the inspiratory pressure, the PIP, and not the driving pressure. You can see that if there's confusion amongst that or miscommunication amongst that, the ventilatory support that the patient's getting is offset by the level of PEEP that is applied. So sometimes people think, and I've seen this in clinical practice, that this is almost a treatment escalation algorithm moving back and forth between these three, that, oh, if a patient fails BiPAP, we should put them on CPAP. If they fail CPAP or can't tolerate CPAP, we should use high flow. Or let's start with high flow first, see where we get. If not, we'll escalate further. I would encourage you to kind of move away from that thinking. They are very different therapies. They each have very distinct intentions of therapy, and their patient selection should match what you're trying to treat for the patient. I'll use the analogy of someone who has shock, and you're kind of doing your differential diagnosis and maybe thinking of obstructive shock, but you don't add antibiotics if you have a PE, right? You treat the PE. So you have to understand what you're treating and pick the right therapy to go along with that, instead of just kind of moving along or moving in between all of these different therapies. So we'll look at a couple different patient populations and what they may benefit from or not. COPD is certainly one. Patients who have hypercapnic respiratory failure really benefit greatly from non-invasive ventilation. This was a Cochrane review that was done that you can see that in all of these randomized controlled trials that were a part of the review, all of the outcome measures were lower with NIV. These include things like mortality risk, need for intubation, and the benefit was similar for people who had, mild acidosis, but perhaps significant tachypnea and work of breathing. But those who had more of a severe hypercapnic respiratory failure, for patients with, again, primary COPD exacerbation that you're treating, they can actually they respond very, very well to non-invasive therapy and non-invasive positive pressure ventilation. Cardiogenic pulmonary edema is a bit of a different story. They certainly do respond well to non-invasive therapy. We've all seen these patients who perhaps either have some sort of right heart failure, they might have associated hypertension that's exacerbating this, which has then led to pulmonary edema development. Using CPAP therapy, non-invasive therapy, was really demonstrated in this review to reduce hospital mortality and endotracheal tube intubation. These are patients who, if treated, their underlying cause is treated either with diuretics or antihypertensive medications. They really actually turn around fairly quickly. So using a non-invasive approach is probably better than using an invasive approach. There's little to no difference in outcome benefit depending upon where the cardiogenic pulmonary edema comes from. If it's biventricular failure or hypertension, they all benefit from using CPAP. Every respiratory therapist that I interview for a job, we ask them about their non-invasive approach, and there seems to be some shift into using bi-level for patients with cardiogenic pulmonary edema. Historically, it's really been CPAP that's been used. Again, there is a vast difference. In this review, it showed in the subgroup analysis that there was no difference in outcomes in using CPAP versus bi-level. However, what's important is that we recognize that the mean airway pressure, the EPAP level, is very elevated. These applicants for RT jobs that I interview, we ask them, what would you typically start someone off on BiPAP? What settings would you use? And they say something like 10/5, 12/6, which is probably okay for a patient that has a COPD exacerbation. If you're going to use BiPAP for cardiogenic pulmonary edema, you want to make sure that that CPAP or EPAP level is elevated. So you want to pick something like 12/8, 15/10. Using an EPAP level of 5 or 6 is probably going to be insufficient to stop the progression of the pulmonary edema. So keep that in mind if you're using bi-level to treat cardiogenic pulmonary edema.
It didn't come.
There's a lot of information on using non-invasive therapies post-extubation. There are many benefits, things like, of course, shortened invasive ventilation time, preventing extubation failure. If you don't have an endotracheal tube, of course, your rates of ventilator-associated pneumonia will be lower. However, it is really not for everyone. There are several randomized controlled trials that look at who most benefit from using non-invasive ventilation or CPAP or non-invasive respiratory therapies post-extubation. The first randomized controlled trial looked at 406 patients who all passed an SBT, and they prophylactically used non-invasive ventilation, and there really was no difference. But then other trials that went on looked at who really will benefit. And I think this patient selection is very important to know and to keep in the back of your mind when treating patients clinically, because identifying these patients, identifying these conditions will allow you to place non-invasive modes more prophylactically than in a rescue setting. So patients who have neuromuscular disease, it can help bridge their gap after extubation and avoid tracheostomy. Patients who do have hypercapnia, underlying hypercapnia like a COPD patient, patients who have congestive heart failure and ineffective cough, patients that have failed more than one SBT where you think that their rate of extubation failure is a little bit higher. I recognize that that is vague, but it takes into account the entire picture of the patient. Upper airway obstruction is another one that is very important to think about using CPAP or BiPAP post-extubation. And this isn't meant to talk about patients who have an oncologic process going on, some sort of fixed upper airway obstruction. It's really meant to discuss those patients that have obstructive sleep apnea, who are perhaps obese, and as they're maybe a little bit more sedate, then after extubation, they might have an increased risk for failure. Who not is also a very important question to ask. And as I mentioned, once the patient has failed extubation, you're seeing signs of either significant increased work of breathing into tachypnea, retained CO2, or as they get further into failure with, further their CO2 escalating, but their respiratory rate decreasing. Those are patients where using non-invasive therapy is not going to avoid reintubation. it really does just prolong the rate of getting to intubation while increasing their likelihood of ICU mortality. So if the patient has already failed, it's best to just proceed directly back to intubation. Immunocompromised patients actually respond very well to CPAP therapy or BiPAP therapy. These are patients who have, they're not in respiratory failure, but perhaps in some respiratory distress. Patients who have hypoxemia or hypercapnia after, a solid organ transplant was one group. Others who have pneumonia, who are, from their immunocompromised state, they do show benefit. Non-invasive ventilation shows benefit against things like intubation rates and improved mortality. Again, once this patient population has progressed to full respiratory failure or severe respiratory failure, they're likely not going to improve with non-invasive approaches. And what we want to make sure is that we're, getting them ahead of the curve before they get there, and really avoiding that invasive route if possible. Using non-invasive approaches for ARDS is at best controversial. There are really no large randomized controlled trials that can point us in one direction or another. Patients who have mild ARDS have been shown to benefit from using non-invasive approaches with, lower respiratory rate, improved work of breathing, lower intubation rates. But the highest rate of failure of non-invasive ventilation is with patients with ARDS. There are, like you can see, many studies that have shown that the success rate is very, very low. And as I think about these types of patients, where we all know that a staple in treating ARDS is the use of positive pressure ventilation, where you are combating perhaps significant atelectasis or fluid in the air spaces. Using a non-invasive approach where the positive pressure applied to the lungs is perhaps intermittent is typically not successful. Although it might not, their intention may not be that it is intermittent. If the mask moves, if there's a large leak, if there's disruption, with the tubing, that can all lead to a leak and loss of positive pressure ventilation, which patients with ARDS have a significant higher likelihood for prone to collapse. So if the ARDS is moderate to severe, certainly intubation and invasive ventilation is the most appropriate approach. Patients who have ARDS combined with shock are very, very poor candidates for NIV. The metabolic acidosis that develops along with the severe hypoxemia are really too much to overcome and to treat with non-invasive therapies. They really should be intubated and placed on mechanical ventilation and controlled ventilation, so that way we can manage both of these things in the most appropriate way. So proceed with caution. I'm not saying don't do it. I think there's more and more information and data that would support this, but I do think that we can't just set it and forget it in these patients who have significant parenchymal lung disease. Asthma is another group of patients where using non-invasive ventilation can actually improve some of their outcome measures, as well as avoid intubation rates. One thing that's really interesting as we think about acute asthma is not always just the supporting of the respiratory muscles, which certainly is an important feature, but it's also delivery of bronchodilator medication. Patients who have significant tachypnea, have short inspiratory times, breathing spontaneously on their own, might not have the ability to have great deposition of the aerosol, and really will not receive that benefit of the medication. If we can support their tidal volume, give them a larger tidal volume, perhaps slow their respiratory rate, allow this better inspiratory time as well as expiratory time, the deposition of any aerosolized particles that are, being delivered goes up. There certainly will be impaction of the bronchodilator therapy on the patient's face, especially if they're using a oronasal mask. There will be some impaction on the patient's face, but we're treating the bronchodilators to effect of the patient, and so there's going to be loss either with a non-invasive mask or just a regular aerosol mask, either on the face with the positive pressure or to the atmosphere if the patient's breathing spontaneously. So for acute asthma, non-invasive is certainly something that I would try, although these are not really high-powered studies. The N of the studies is fairly low, so it's something that we certainly need to think about and explore a little bit more. Community-acquired pneumonia is a difficult one to tease out. If that is the only reason why the patient has respiratory failure, their success rate with non-invasive ventilation is typically very poor. If there are other underlying respiratory or cardiac conditions and they have a community-acquired pneumonia in conjunction with that, using non-invasive ventilation to support their all of their comorbidities, the success rate is a little bit higher. So you have to think about the patient progression. The predictors of failure are well defined. And so if you place a patient with community-acquired pneumonia on non-invasive therapy, and you see some of these signs of failure, you should not kind of continue the therapy. You should perhaps progress towards intubation. A great colleague of mine, Dean Hess, has a saying that we need to beware of the seduction of the pulse oximeter. And by that, what we mean is for all of these patients, we could probably make the monitor look better. We could probably make their blood gas look better. However, if we're not mindful of the patient selection and who we're actually applying what therapy for, we might not be improving any outcomes. So just be careful. Again, you place 100% oxygen on a patient, their saturation will certainly go up. This is another controversial topic that, I think everyone probably has their own personal belief on whether or not non-invasive therapies are appropriate for patients who are either DNI or comfort measures only. Want to ensure that we're all mindful of the distinction that these are not the same thing. A patient who has severe COPD might have requested that they not be intubated. However, they will certainly benefit from BiPAP therapy if they come in with an exacerbation. So just because you're a do not intubate doesn't mean that you should not, be considered for non-invasive therapy. Patients who are actually at the end of life, perhaps on comfort measures only, or don't wish to be intubated again, it really is a personal decision. The aim is certainly to reduce air hunger and discomfort for these patients. Some people feel that a great comfort in using non-invasive therapy. Other people feel that the mask actually provides more discomfort and choose not to use it, but rather to treat their work of breathing and their air hunger symptoms with specific medications. But we do want to make sure that we're asking the family and or the patient, if possible, what their wishes are, how they're feeling, and how they want to approach this, and not just make an assumption that because the patient either is do not intubate or comfort measures only, that we should not offer this therapy. Pre-oxygenation for intubation is actually something that is more and more common, I think, now, using things like high flow oxygen therapy or using non-invasive therapy. This is typically done, as you know, with a bag valve mask. You might need to use an elevated PEEP with a PEEP valve on the mask, depending upon what their respiratory failure is coming from. But when you're trying to deliver manual ventilation at this time peri-intubation, it can sometimes be very difficult to maintain consistency. Things that impacted are things like airway obstruction, a leak around the mask, the inability to actually understand which pressures are delivering. So using a non-invasive device may improve the oxygenation to the patient and allow for a larger window and more patient stability during intubation. I will say that logistically, it's a little bit challenging when patients are not already on non-invasive therapy to, bring an entire device into the room to work through those logistical challenges of cramped space and needing also to have the ventilator close by when the patient gets intubated. However, if the patient's already on non-invasive therapy, it might be more beneficial and more consistent to use the device instead of using a bag valve mask for pre-oxygenation for intubation. Post-op respiratory failure is another selection of patients where non-invasive ventilation certainly is beneficial, but in a subgroup of patients that have either abdominal surgery, cardiac surgery, bariatric surgery, or organ transplant. This is not for all post-op respiratory failure patients. A lot of these patients have impaired gas exchange from pain after surgery. And so providing non-invasive therapy can overcome that and can help relieve some of that impaired gas exchange. I put in this slide of when to escalate, and I want to make sure that the point is clear. It's not to escalate again in between the different therapies, but to escalate from the therapy that you're on to perhaps an invasive therapy, because non-invasive support is not always best for these patients. You have to understand and be very mindful of how the patient's progressing. Is there any improvement? If there's no improvement within 1 to 2 hours, the likelihood that this is going to be a definitive therapy is very, very low. That's when the patient should, whether they're progressing and getting worse, declining, or they're really staying the same, that you haven't seen any improvement, that should be a cue to you that this therapy is not as effective as we would hope it to be. At our institution, we do have a policy that if there's no improvement within the first 2 hours, the patient is automatically moved to an intensive care unit for a higher level of monitoring and likely the need for intubation. As I mentioned, there's many technical considerations with non-invasive respiratory support, really non-invasive support for many different disease processes. The primary one is device selection. You can either use a critical care ventilator or a home care device. Some of the differences are things like leak compensation. So in a critical care ventilator, it has the ability to measure the leak and to actually either increase the flow or the pressure to maintain the level that you have set. So often using a critical care ventilator when the patient's in acute respiratory failure, you'll get a higher level of success rate because the ventilator can overcome those leaks that are in the system. A home care device, those small devices that are used for patients who have obstructive sleep apnea or patients who are more stable, even ALS patients who are using a home care device more routinely, don't have as great of leak compensation. The oxygen delivery is also very, very different between the two. As you know, in a critical care ventilator, there's a dial on the front that you can set the FiO2, and based on the flow, there'll be a fraction of oxygen that is fixed coming from the device itself. In a home care type ventilator, there is no dial for oxygen. So what we have to do is with a couple different, adapters and contraptions, we actually bleed in oxygen from a flow meter that's on the wall. This is a very similar principle to the high flow pictures that I showed you earlier, where if the flow through the circuit is higher, and the oxygen bleed in is fixed, your net FiO2 is going to be lower. So really, with the way that the flow is in these home care devices, even if you have the flow meter set all the way up in an acute situation, the highest FiO2 you're going to get is somewhere around 0.4. So you do have to be mindful of that, and select the right device to make sure that you are treating the patient most appropriately. Interface selection, of course, helps with patient tolerance and patient compliance. Many people who are firm non-invasive therapy believers and users, they have their mask and it has to be their mask and they're most comfortable with their mask. And so finding a way to incorporate that into their care during an acute situation can certainly change the compliance with therapy. There are many different interface selections now. There's, typical mask that you might see in an acute care setting. There's also very high-end masks that are made of like gel or memory foam, that typically are used for more of an outpatient setting, but can certainly be can be meshed in between. There's a nasal mask, an oral nasal mask. There's also a hybrid mask that covers a bit of the mouth, but then also has nasal pillows. There's a total face mask, which I think for many of us, seeing that, we kind of have the impression of that's never going to work. It's a mask literally that goes from the forehead all the way down to the patient's chin. What I will say is patients I've used it with have absolutely loved it. There are things like they can read because they don't have the mask sitting right on top of their nose. They can watch TV because it has more of a clear view of their whole face. So there are certainly benefits to that mask, although when I look at it, I tend to think like, I don't really want to use that. Nasal pillows are something that can be used, although I'll caution you in the fact that in acute respiratory failure, that may not be enough, especially if the patient's mouth is open and there's a large leak of pressure out the mouth. The pressure delivery amongst these are variable. Again, if the mouth is open, then the patient might not be seeing all of that pressure. There's also skin concerns, of course, that go along with any non-invasive therapy device. Some patients who need this therapy more long-term, what we do is alternate between different mask types, even different mask sizes. It allows the point of contact to be varied, and so we avoid things like skin pressure injuries as well as pain on those different sites, which just increases the tolerance to therapy. Optimizing asynchrony is another important technical consideration that really will help with the success or the failure of therapy. Selecting the appropriate mode, especially when you're using an acute care ventilator, is something that is important. The more control variables that you have, that can lead to a higher rate of asynchrony. So if you're using an acute care ventilator and you think this patient has severe hypercarbic respiratory failure, you might think the best thing to do is to set a rate, set an inspiratory time, so we make sure we lower that CO2. However, that can lead to asynchrony, especially because many of these patients are not going to be sedated to the level of either apnea or tolerance to the device. So for improved comfort, which means better tolerance, you want to think about things like using a pressure support mode, where the patient can set their own respiratory rate, they can set the timing of their breaths, they can set their inspiratory time and flow demand as well. So in conclusion, the question is less actually best? I think for some patients, the answer is yes. For patients with hypercarbic respiratory failure, neuromuscular disease, some patients who are at end of life or who have obesity hypoventilation syndrome, Non-invasive ventilation is certainly shown to be beneficial and is best for these patients over something like invasive ventilation. For patients who have obstructive sleep apnea, and I should also include in here cardiogenic pulmonary edema, CPAP is certainly the way to go instead of intubating those patients. In patients with hypoxemic respiratory failure that's on the mild to moderate side, either CPAP or high flow nasal cannula can help them avoid intubation. Again, I'll caution against the set it and forget it. If the monitor looks better, it doesn't necessarily mean that the patient is overall improving and that your therapy is doing exactly what you hope it to do. That may be the case, but you do have to have closer monitoring and a higher investigation into either signs of improvement or signs of failure. And then the device, the mask, and the mode selection do require great expertise, but can greatly influence the tolerance and success of the therapy. And with that, I thank you.